So welcome to the CBITS webinar, which is hosted in collaboration with the Society for Digital Mental Health. Just so you know, this session is being recorded. Today we're going to be, have a number of talks from the people on your screen there who are all faculty here at CBITS, and I'll talk a little bit about that in a moment. But first, just a few announcements. This is the last webinar of this academic year, so we're going to be pausing for July and August and then resuming in September. The speakers for September will be up on our website, but some of the people that have already agreed to speak are Lyle Unger, who's from the University of Pennsylvania, who is a computer scientist who uses machine learning methods to understand language related to mental health through social media and text messaging. And Jessica Schleider from Stony Brook University, who does research with very brief digital interventions, which are very effective. So please, after today, come back in September. Another couple of announcements around the Society for Digital Mental Health. We are holding our first inaugural conference next week on Monday and Tuesday. It'll be 2 half days. The focus is on implementation and policy. There will be keynote talks from David Clark, who is from the UK. He was instrumental in putting together their IAP system, their system for mental health in their National Health Service. And he'll be talking about digital mental health treatment rollouts within the British healthcare system. And then Danzim Chaudhry, who will be speaking about digital mental health work that she's involved in with United Healthcare. And there will be expert panels on digital mental health, on evidence standards for digital mental health, as well as reimbursement methods for digital mental health. The society is free to join, and we'll post in a minute I'll post in the chat in a little bit the URL for the annual meeting. So for today, I'm really excited to be talking about the Center for Behavioral Intervention Technologies. So we've been doing this webinar now for about 2 years, and we realized that we haven't really talked about ourselves. So we're going to take this opportunity. So I'll present a little bit about the background and the evolution of our thinking, and then we're going to have 6 short talks from faculty here who are doing, I think, really groundbreaking work. So I'll go ahead and share my screen now. I'm assuming you can see it now. Is that right? All right, I'll go ahead unless I hear something different. So the focus is going to be on here is really on integrating design and implementation for digital mental health. And today, the Center for Behavioral Intervention Technologies has 8 faculty representing psychology, human-computer interaction, communications. There's a lot of research going on in multiple conditions, including depression, anxiety, eating disorders, in a lot of different settings, including university settings, community mental health, public nonprofit agencies, and then there's an NIMH center grant here where we're integrating digital mental health into healthcare settings, including primary care, OBGYN, and geriatrics. And we also have basic research on sensing. So the center started 11 years ago. Last year was our 10th anniversary. So it was founded in part with an NIMH center grant. And using that center grant, the School of Medicine was generous enough to, add some funding as well as add a few faculty lines. And these faculty members, some of them you may know, Stephen Schuler, who is now at the University of California at Irvine, Jenna Duffasey, who's at the University of Illinois in Chicago, Michelle Burns, who's gone into industry, Mark Begale was our tech core leader, Joyce Ho, our research director. And we started out with a mission that is similar to what we have today, to harness technologies for mental health. We started out with a web-based intervention. This was 2011. We created the first web app, app using phone sensor data, and we had an early attempt to use NLP to create a conversational agent for mental health. That NLP at that time proved really not robust enough to be able to create a functioning conversational agent. And generally, I think, we all at that time were really excited about using technology. And I think a lot of us realized that this was a much more challenging problem than we realized. So one example was, using sensor data. We thought that we could just harness the data out of a Nokia phone and be able to identify what people are doing and use that information to be able to intervene. And we, fairly quickly, and that really was, I think, the first phone app that used those, that tried to do that. But we quickly realized that the problem of understanding mobile phone sensor data was a much deeper problem than we had anticipated. And so that continues to be kind of an area of basic research that we're engaged in. But again, this was really youthful exuberance. The other was sort of youthful exuberance and ignorance was in our design of interventions. So this is an example of a web-based intervention that we designed at the time for depression. And you can see there's a landing page there in the upper right-hand corner where people can navigate. We had videos that kind of explain things to people. We had tools like this activity management tool, and you can probably already see just kind of what a mess this is. This made sense to us, this activity tool, but users found it kind of unusable. And the videos, we put a lot of effort into creating videos. Many of them kind of missed their mark. So we began to realize that we really needed to involve end users in the design. What we were doing was trying to take psychological interventions, things that we know if people will do them, that they'll get better, and put them into a digital format. But we quickly realized here that we needed to embed that design in the fabric of people's lives. We needed to engage users give them a voice in the products that we were trying to create. And so we began doing that, and Madhu Reddy, who is a longtime collaborator of mine, is unfortunately not here today. But with him, we really moved this center in the direction of integrating human-computer interaction and design using a variety of different methods: interviews, focus groups, workflow observation, co-design workshops, usability testing. And that got us to a point where we actually were creating things that were fairly usable. So this is some data from a long project that we had in Telecare, where we created a digital mental health platform. We were able to get good results, solid reductions in depression, but the right-hand graph is the engagement. And so, how in a lot of digital mental health treatments, you see kind of a hockey stick. People start out using it and then they stop. But in this platform, we got pretty consistent use over 8-week treatments. So this kind of, I think, showed to us how important it is to embed design into digital mental health research. And that trial was done, that last trial that I showed you was done at the University of Arkansas in primary care. It was just a couple of years ago. And we embedded it in primary care. And this you see a picture here of a workflow, which I won't burden you with, but we tried to integrate it into the EHR so that physicians could make referrals. And there was an alert, an EPIC alert that came up when somebody screened positive for depression. They could recommend that they go receive this service. We also reached out directly to patients, for when they had a positive PHQ. We messaged them directly. We had flyers and so on. So, but when we looked at how effective these referrals were, notice the bottom, the top row here, 73% of the study enrollment came from direct outreach. So contacting people when they had a positive PHQ. And only 4% came from physicians, even though we had it embedded in Epic. And yet, of all the, of these people that we were contacting, directly through the EHR, the direct consumer, only 4% of those people actually, took part in the study, actually received the intervention. Whereas 50% of the physician referrals made it in. And so, what this is showing, if you're trying to treat a population, what you really want to see is something closer to that 50% of people who are suffering from a problem are getting the treatment. And so what we began to realize is that user-centered design is not just for the patient, but it's really also we need to be doing this for the healthcare system, for the providers. We need to give all of these stakeholders a voice in how the system is going to be designed. And so we've developed over the last few years what we call the accelerated creation to sustainment model. And so this is the research model that we've really been using within the Center for Behavioral Intervention Technologies. And the aim here is to be rapid, to get from idea to end of trial and deployment quickly, and to minimize this research to practice gap where we create tools that can't be really effectively integrated into the healthcare system. And so there are 3 phases here. The first is, what we call the create phase, or it might be adapting a tool. And here we're getting input from all stakeholders, not just the patients, but also the clinicians, anybody who's delivering the treatment, the healthcare organization, and we're not only designing the technology, but we're designing the protocols for how a nurse or a social worker or a paraprofessional is going to be interacting with a patient. We're designing the implementation plan, understanding the workflows so that we can fit it into those workflows. And then we move to a trial, hybrid trial, which measures both, in which we look at both effectiveness and implementation. But importantly, we also continue to optimize the treatment and the protocol and the implementation plan as we go along. And then finally, we release start to remove all of the research supports to try to get it to work, to be sustainably implemented. So this is the model that we're working with. Today, I think the talks are going to be mostly around this create phase. And there's going to be, you're going to hear from 6 people. So Rachel Kornfield is a human-computer interaction communication scientist with us. And Jonah Meyerhoff is a psychologist. The 2 of them are going to be talking about a project that we're doing with Mental Health America. They'll be talking about 2 different aspects of it. Kaylee Cruzon is another, will be a faculty member here in a month. So we went ahead and included her as faculty. And she'll be talking about also working with Mental Health America, non-suicidal self-injury. Maya Jacobs is a faculty member with us who also is jointly appointed in computer science. And she'll be talking about a system that she's developed with cancer. Ashley Knapp is a psychologist here with us through the Department of Psychiatry. And she'll be talking about community-based engagement. And then Andrea Graham, finally, another faculty member with us through medical social sciences, will be talking about interventions for eating disorders. So with that, I'm going to turn it over to Rachel. And
great, thank you so much, David. Let me just share my screen. All right. So I'm very excited to be sharing about some of the work that we're doing on text messaging for young adults. And this kind of illustrates a couple of the points that David was just sharing, kind of illustrates our user-centered design process that we use here at CBITS, as well as really trying to design for a particular implementation context. So I'll talk about the point at which young adults are self-screening for different mental health conditions. So some background, which I'll keep very brief because I think that everyone on this call is really aware of the mental health crisis that young adults are facing. Rates of mental health conditions like depression and anxiety were already high and rising before the pandemic and have only increased in the past couple years. However, many young adults are not interested in formal treatment or are unable to access them because of barriers like costs. We know, however, that young people regularly use mobile technologies and especially texting. So this is the most used app on the mobile phone. But really the problem we're trying to address in this work is that a lot of the tools for young adults are designed with and for those who are already connected to formal care, not that majority of young adults who are actually uninterested or unable to access formal care. And they may have a different motivational profile or really different needs than those connected to care. So we really wanted to understand those needs here. And that's where our partner, Mental Health America, comes in. So Mental Health America is a nonprofit advocacy organization for people who have mental health conditions. And they have a lot of traffic to their website, particularly around self-screening. So people who are looking to understand whether they have a mental health condition, trying to understand their symptoms, and potentially connect to resources. But importantly, most of those people who take these self-screenings, and I think it was 5 million last year who took self-screening, so it's really a considerable number, they're generally not looking to connect to formal mental health services. They know they need help, but they don't want traditional treatment. So we really wanted to understand what they would be receptive to when they complete these self-screeners. So we worked with Mental Health America to recruit directly as people were completing these self-screeners, receiving results, which might look something like this, and engage them in a series of user-centered design methods, activities, which I won't go into, but I do want to share that they were all remote. And we really emphasized lowering the barriers to participation so that we could engage as many young adults as we could and provide anonymous, text-based, asynchronous ways of participating for those who were more comfortable with that. And so through Mental Health America, the tools that we design can eventually be made widely available outside the care system. So a couple of questions that we're really trying to answer with this work are, at the point of self-screening, how do young adults think about or what would convince them to adopt a digital mental health tool? And then second, what are the sorts of content they want these tools to deliver and how do they want to navigate that content? So just because this is a brief talk, I just included some papers that recently came out related to this design work that you can check out if you're interested. So as far as adopting digital mental health tools, consistent with what we know, we saw that a lot of these young people were not interested or potentially not ready to connect with formal mental health resources, largely due to cost, but also because of preferences for self-reliance. They had often used other digital mental health tools, smartphone apps in particular, but not stayed engaged. And they gave us some really helpful advice about how to present tools for them. Specifically, they knew they needed help and they wanted us to connect to that need and to present tools as a scaffold for their own self-help process. So one participant gave us this advice as far as promoting our tool: just be like, if you know you need help, try this new opportunity to help yourself. And they also really appreciated the reach and convenience of text messaging, which was compared favorably to apps in particular, which you have to download and open and remember to use. So one shared, I'm always on the texting app. I don't have to open something else. Now, as far as the types of content that people were interested in, we found that they really wanted diversity and variety. So being able to roll out new types of new psychological strategies and new types of interactions over time was really key. So we presented them with a variety of psychological strategies, from CBT, from acceptance and commitment therapy, from positive psychology, and they were really receptive across the board, as long as these were kind of introduced as options for them to experiment with and see if they liked, and not ones that they were locked into continuing with if they didn't resonate. We also found that they really wanted diversity as far as interaction types. So when we started this work, we were thinking a lot about, push-based messages, providing psychoeducation about the strategies, kind of tips, prompts to try them out. But what we ended up with was really a much broader set of different types of interactions that were much more bi-directional. So we ended up including peer stories, opportunities to compose support messages for peers as well as receive support messages, and reflection questions that people could respond to with free text. And that really gets to the second bullet, where we really needed to take advantage of the interactivity that text messaging allows and allow for self-expression. And this is explained by a participant who says, if I can connect it back to something in my personal life, it'll have more meaning and therefore I'll remember it better. So really those opportunities to think through and respond in text, we're seeing as highly engaging. And then finally, agency is really key with this age group and in general. And so opportunities to make choices about the content they see and also provide feedback. So that could be ratings, could be describing an issue. That was seen not just as a burden, but also a benefit as long as it would lead to more personalized content in the future. So this is just a preview of where some of this work is going. So this is a text messaging tool that we've developed called Small Steps SMS that provides daily interactive messages. We've built in diversity as far as the psychological strategies and the interaction types that it supports. And it supports both passive and active personalization. So active meaning people might select the topic they want to work on or select between different interactions they could have that day, but also passive in the sense that we're collecting ratings and measuring user engagement with different content types. Using reinforcement learning, we can eventually deliver more of what people like and respond to. So this tool will be available for free eventually on Mental Health America's website. It's fully anonymous. And right now we're kind of further refining the design, and we will be running some clinical trials as well. So thank you so much. I'm going to hand it off now to my colleague, Dr. Meyerhoff, who will also be talking about this project. Thank you.
Thanks very much, Rachel. So let me just share my screen. All right. Okay, so thank you very much. And today I want to talk about the process of building a digital mental health intervention in collaboration with a community partner. So as David noted, at CBITS, we use the Accelerated Creation to Sustainment framework to develop technology-enabled services. And I specifically want to highlight the sustain phase here within the ACT framework. Sustainment is a really important part of the way we think about technology-enabled service development, because most research tools die after their research funding is over. And ultimately, this means that the people who need it most ultimately never actually get to benefit from these tools. And so sustainment becomes a critical component of disseminating an intervention. So in the sustainment phase, there's an ongoing evaluation of the technology-enabled service or intervention or implementation of the tool. And if any problems in these domains are detected, there might be some small redesign efforts, but the overall goal of the sustainment phase is to ensure that this service can stand on its own without any research support or continuous research support, which is why it is extremely important to involve community partners from the beginning of a research project. And community partners are the ones who ultimately need to be able to implement the intervention after the research support is removed. So it becomes really important for us to work closely with them in order to understand their organizational needs, their constraints, and the very real costs of delivering an intervention. So as part of our process of designing and developing and evaluating a brand new adaptive text messaging tool that you just heard a little bit about, to address depression and anxiety symptoms among young adults who are non-treatment seeking, we partnered with Mental Health America. As you just heard, they're the largest mental health advocacy group in the US. So since 2014, MHA, or Mental Health America, implemented screening tools on their website. And you can see a screenshot of what that looked like on the right. And this is to help provide entryways to people who are curious about learning about their own symptoms, as well as gaining some self-directed ways to address those symptoms. And our partnership began as we started to talk about ways to help this group of MHA users who weren't interested in formal treatment options, but were experiencing some very real suffering. And the outcome of these early talks was a series of proposed self-management tools that visitors to MHA's site could use to help address their needs and reduce their symptoms after seeking information about their mental health. And so with MHA as our partner, we ran several design studies, which you just heard a little bit about from my colleague, Dr. Cornfield. And we built tools that extended the points of service at which MHA actually interacted with its site visitors. And the tools that we developed enabled MHA to engage their site visitors beyond just information seeking by supporting them throughout their mental wellness journeys. And ultimately, and so throughout this work, we had a number of really important responsibilities to our partner. First, we had to ensure that the tool we developed met MHA's larger organizational priorities and goals. And the first was connecting information-seeking individuals to supportive tools. Next, we worked with MHA to define the target population of interest. And MHA noted the need for a transdiagnostic tool. And so to this end, we developed a tool that addresses affective symptoms broadly. And we have plans to extend the reach of the tool that we develop to broader populations. So for example, individuals with bipolar disorder or individuals who experience self-injurious thoughts or behaviors. Third, MHA's user base is more diverse and it's younger than the general US population. And so as such, it was really important that the tool we designed needed to be designed with diversity and young people at the center as target end users. And finally, MHA has a robust technological infrastructure, and the tool we built would need to slot into their existing service framework with minimal additional overhead. And so each of these design considerations was operationalized and kept at the forefront as we designed and built our services. And so to ensure that these key responsibilities were met, we developed a strong collaborative process with MHA. So this involved bi-weekly meetings with MHA leadership, and this was to review progress, address any design and logistical blockers. And then we worked actually directly with MHA staff to develop content in the organization's focus, voice, and tone. MHA staff writers iteratively reviewed and edited all the pieces of content we developed to ensure that it fit within their style guide and matched their voice and tone. And together, we actually created over 53 pages of online content for the web and over 1,000 individual text messages that can be delivered to users across this 8-week program. Then MHA staff and leadership piloted our intervention and provided feedback to ensure that the clinical content was responsive to the diverse audiences that MHA serves. And finally, MHA staff reviewed links to external content that was included in the intervention. These are things like videos, audio, psychoeducational information, and they provided alternative suggestions for internal or MHA-related content. And the resultant program is a robust 8-week adaptive tool that meets the key objectives and needs of MHA and was co-designed with MHA Young Adults. By building this tool with sustainment in mind, we were able to build a strong working relationship with MHA, one that comprised interrelated goals and trust, and we established a strong collaborative process that resulted in multiple joint grant applications, and we're extremely excited and hopeful that these community partnerships will continue to lead to mutual growth. Thank you very much, and I'm now going to pass it off to Dr. Kaylee Kruzan.
Thanks, Jonah. Let me share my screen. Okay, I assume you can see my screen. Yeah, I'm very happy to be here and talk to you today about what is in some ways an extension of the work that you've seen from Rachel and Jonah. And so specifically, I'm excited to share with you some work that we've done to develop a intervention for young adults with non-suicidal self-injury. So I'll start by giving you a bit of background and context around the scope of this project. So first, NSSI is a prevalent problem globally. So around 13% of adolescents and 17% of young adults engage in non-suicidal self-injury. However, most young people with NSSI don't seek formal treatment or disclose their behaviors to others due to many of the barriers that we already know a lot about. Yet they do share openly online and report receptivity to digital intervention. So to address this problem, we aim to develop a publicly accessible digital intervention for young adults who engage in NSSI with the goal of bringing evidence-based practices into the hands of those who may not otherwise receive care. And to do this, we partnered again with MHA. And MHA has a vested interest in resources for self-harm since it's a behavior that many of its visitors already engage in. Though MHA doesn't have an NSSI screener currently, we know that 71% of those completing the PHQ-9 in 2020 reported frequent thoughts of suicide or self-harm and never received any type of mental health care. And also over 11,000 users reported an addiction to self-cutting in 2021 via the addiction questionnaire. So given that over 5 million people take the screeners on MHA annually, there are likely to be many more who engage in NSSI. Therefore, to realize our goal of getting the intervention into the hands of those who need it, we need to work with MHA to develop a screener which will provide direct access to our intervention and hopefully other specialized resources for this population. So based on some initial conversations with MHA and informal needs assessment that we conducted, we expanded the scope of this project to focus both on developing the deployment strategy, so the screener, and the intervention simultaneously. As you can see here, this involves many different phases. For AIM-1, this includes iterative screener development with MHA visitors with a history of NSSI, our research team, and will go on to include preliminary data collection and validation of the screener for use through MHA. For AIM-2, we began with interviews with 20 young adults who are in the midst of iterative prototype sessions, and we'll go on to do some software development, usability testing, and ultimately a randomized control trial. For the remainder of this talk, I'm going to focus on some findings from our user-centered design work. So in that create phase of the ACTS model, which focused on developing the intervention. So we had two aims at this phase. One was to understand how young adults already engage in NSSI self-management. And the second was to identify opportunities and challenges for a technology to support them in their NSSI recovery. So here in that first phase, we learned that young adults express different goals and motivations around their self-injury. So in these interviews, some described wanting to stop their self-injury behaviors entirely, while others described goals to reduce the frequency of NSSI or the severity of cuts over time. We also learned that young adults use many different strategies to self-manage already, and these were folks that were not yet engaged in treatment. But they found that their efforts to self-manage were largely not satisfactory. They weren't able to curb their desire or urge to injure, and they most frequently endorsed avoidance strategies rather than approach strategies, which we know to be clinically effective. Finally, technology was a critical part of their self-management practices, both as a medium to engage in coping strategies like distraction or meditation, and as a way to get information and support, though this was usually when they were younger, more so when they began self-injury as adolescents. Next, we wanted to understand how a technology could or couldn't be useful to them. And we found that young adults really wanted an intervention to allow them to connect with support safely. So not in the way that they had been receiving it through other online communities. And they suggested peer stories that would provide them with validation and information, but not put them at risk of harmful content. Most importantly, they wanted the app to help them track patterns to increase understanding of triggers and provide personalized recommendations when they needed it in moments that they most needed support. And then finally, they were interested in an app that could help them with their self-injury behaviors, but also they recognized that self-injury was a symptom of a broader mental health concern. And they wanted support for NSSI when it was at the forefront of their experience, but also support for other mental health conditions like depression and anxiety when these symptoms were more significant for them. So some key takeaways of this work at this early stage. First, the individual complexity involved in young adults' experiences is not well represented in this talk as it's very short, but it can be found in our paper where we also discuss facilitators and barriers to use of a potential digital intervention. And I included a link or a citation to a paper that's in press. And basically what we came to is advocating for a person-centered design flexibility approach, given the unique needs of this population, which means that the technology we design should be able to be reconfigured to meet the user's needs. Though the overarching therapeutic approach of the intervention should be consistent across instantiations of the tool, there may be flexibility in terms of user goals and motivation. So what this might look like, it might look like tailoring in the onboarding process to provide inputs within the app to incorporate language that resonates with users. It should also respond to changing priorities. So a focus on NSSI when self-injury really is at the forefront of their experience, and then additional support for other related conditions. And it should include some type of tracking to allow users to learn about and anticipate their triggers and provide tailored directed feedback on what they can do to overcome these triggers and engage in activities that will support their recovery. I'm just acknowledging our partners and some grants that we were funded with. And I will pass it off. So let me share to Maya.
Thanks, Kaylee. And thank you, Ashley, for bringing up the slides. So hi, everyone. I'm Maya Jacobs. I'm an assistant professor in computer science and preventive medicine at Northwestern. And today I wanted to talk about a strategy that we developed for technology deployment in rural Georgia. This was with the goal of supporting breast cancer patients, and it was an approach that we developed with our community partners who were the cancer navigators in order to hopefully offer mutual benefits to participants, to the community partners, as well as to the research itself. Next slide. So for a little bit of context, this is part of a decade-long partnership with the Harbin Cancer Clinic in Rome, Georgia. This image is downtown Rome. It's a really lovely small town in Northwest Georgia that serves patients from all over northern Georgia, as well as Tennessee and Alabama. They serve about 900 patients a year, and about 37% have breast cancer. Next slide. So we were fortunate to begin working very early on with the Rome Cancer Navigators. They are a nonprofit organization made up of social workers and nurses who focus on offering patient support that can't get within formal healthcare settings. They focus on personalized education, counseling, access to resources. Really, their mission is whatever you need to get through treatment, they're going to help you with. And they really became our informants and partners during these years of research. Next slide. So we ran over the years an extensive user-centered design process. It involved interviews and focus groups and technology probes to understand existing healthcare processes, as well as patient support needs. The main finding from this was that all this research revealed to us how different people's support systems are and how different their support needs can be. We really saw this need for more personalized coaching and easier information access. Next slide. And so with that, we developed the MyPath application. This was an application offered to patients on a tablet that offered personalized information to improve information access. The overarching idea being that there's just hundreds of pages of information on treatments and health management strategies, but there's no easy way to get this information quickly when you have a question and you're feeling overwhelmed and dealing with treatment side effects. Now, for the rest of this talk, I'm actually not going to focus on the technology itself, but how we ended up deploying this through the Harbin Cancer Clinic, because we were facing a number of challenges on how to effectively and respectfully provide this tool to patients. Next slide. So a couple of those challenges that we knew we were going to face was that the research team and the technology were unknown to the community. So we needed a way to establish trust in the tool. We also wanted to get this into the hands of patients shortly after a cancer diagnosis, which we know can be a very difficult and stressful time, and we wanted to be respectful of that. What we found was that our partners, the Cancer Navigators, this was really their strength. They were known and trusted within the community, and they were already there at these early appointments and were the expert at offering support during these difficult moments. But what we also thought about was how we could better support the Navigators' mission. One of the challenges that the Navigators faced was that they are meeting with several hundred new patients over a year, but there's only a few navigators. And so they really rely on patients to initiate contact with them when they're needed. And so we saw an opportunity for MyPath to use these personalized recommendations to help people understand when and why they should reach out to the Cancer Navigators. Next slide. So what we ended up doing was creating an education navigator position. This was a position that was supported through the research, but hired by the Cancer Navigators. They work directly in the Navigator office. They work directly with the full team of navigators. And they served two purposes, really. One was to support the deployment, but the other was to provide the navigators with more generalized knowledge of what sorts of technological resources were available for patients more broadly. And so our deployment approach looked like this. Patients would become eligible at diagnosis. The navigators would mention this study at the first meeting that they're already having with patients. The education navigator would then be able to follow up and provide each individual participant with their tablet as well as some personalized training. Next slide. So we ran the MyPath deployment for 2 years, and I just wanted to take a brief moment to reflect on the deployment strategy. Next slide. So there were a few things that I think worked well and a few opportunities to continue to think about how to do these community-led deployments. What worked well was this was an approach that allowed our community partners to really lead the deployment, which Jonah already did a great job of motivating how important it is for that sustainability. It also allowed us to be really respectful of our participants when they were going through these very challenging moments. And then finally, through interviews with our participants, we did find many instances where MyPath did encourage people to reach out to the navigators for support. Where I think there's still opportunity, one problem we faced was that with technology changes and upgrades happening so rapidly, it's really difficult to offer tools for these long periods of time. And I think there's a need to work with technology companies to find ways to better support platforms and software for longer periods during these studies. And finally, we need to consider deployment strategies in a post-COVID world. Our approach relied a lot on in-person visits, but especially for rural communities, there may be opportunities to leverage some of the virtual tools that have become popular in the past few years. And so with that, next slide. I'll just give a quick thank you to the research team that worked on this and the National Cancer Institute for funding this work. Thank you all. And with that, I believe I am passing it off to Ashley.
Hello, everyone. Thanks for sticking with us during this Mad Marathon of Flash Talks. Let me get my slides up real quick, but I'm Ashley Knapp, and I'm not good at multitasking. I wish I could talk through it while I do it. But here we go. Come on, Loga. Great. So I'm Ashley Knapp. If you ever want to get away with not having to use your real picture, go to kovitar.com. I wish I'd get royalties and do a little cartoon. But I'm Ashley Knapp. I'm a research assistant professor within Feinberg School of Medicine, and I'm currently awarded or currently working on and what's being funded as a KO1 Mentor Career Development Award. One of my undergrad RAs actually made this. We're coming out with a website, Youth Digital Mental Health Lab, but I think it really describes well the intersection of the different hubs of my research. Community engagement at the top, because we need a community. We need them in order to really create tools that they'll use that will be sustained. Also, I use a lot of human-centered design or user-centered design methods to understand the needs of users, to understand the needs of organizations, and going into implementation research so that we are creating tools, digital tools that folks use, but that can also be sustained within wherever that tool is being deployed. I'm actually going to skip this slide, but it's very busy. I'll give a background of for time purposes. So with the KO1, what the aim is to co-create a digital mental health intervention with teens at the library as well as their teen services. And so to create and then do pilot testing. And what that last diagram showed, it's iterative. So we really want to take their feedback and adapt the prototype in order to make it reflective of the community. But for this talk, I'm going to focus more on partnership development and especially partnering with the community. Because I think it's not an area talked about a lot, and it's just digital mental health needs to be grounded in this if we're going to make tools that folks use, but also that's sustained whenever research goes out. So you may have said, what, a library, mental health? How does that go? Well, let me tell you. So I met with several folks or organizations in Chicago thinking through who would be a good partner or who has the same passion and mission of providing mental health resources for youth. And I was introduced to the Oak Park Public Library, and we really found that we shared that common mission of wanting their teens to have reliable mental health resources. And then what I also found out while I was doing this work is there is a shift in the US and for libraries to provide more than just literacy or other services you may think. So here's a Chicago Tribune article, and to quote a library director from the Addison Library, we started looking at patrons in a different way, that maybe some of the behavioral issues we were having at the library were stemming from other needs we could address. So it's a really neat shift. And even folks that I work with, who shout out, these are my fabulous partners at the Oak Park Public Library. From top left to right, we have Stephen Jackson, we have Robert Simmons in the middle, Latanya Jackson in the top right, Darcel Washington on the bottom left, and Amy Hoffmackel in the middle, and then Alex Gutierrez. So they comprise the folks that I've been working with. And then just to show you an example of team services at the Oak Park Public Library or folks that they serve, that would be on the right. And you can see Stephen's right here. So these are the folks that I work with, and it's just been, I guess it's been 2 or 3 years now, but the KO1 has really allowed for deep engagement. And then also we received a partnership development secret that I'll talk about. And if you're not familiar, it's of ARC, which is Alliance for Research in Chicagoland Communities. You can Google ARC Northwestern. It's a fabulous center here at Northwestern that brings community folks to the table and faculty to the table to learn together, to create together. It's, I can't speak high enough praise of it. But for this, what we wanted to do was, before even starting the design of the prototype, cultivate a robust community academic partnership. So what does that mean? We wanted to create 2 advisory boards, one comprised of teens and then another comprised of adult local members. So the adults were teachers, parents, other librarians, and other gatekeepers within the community. And they helped us with so much, from creating the questions to facilitating the community advisory boards. And the trust was built up so much that I'd be like, can I have the follow-up question? And so I was like, wait, we're going this way, then we can come back to you. It was so fun. And I don't have time to go into this, but please shoot me an email. We created really neat community facing materials that really captured the takeaways from the project. And then we have about 6 minutes left. So I am actually going to skip. I have a lot of fabulous community partners. Hughes Who Technology Studio, starting to make other partnerships as well. So I'm happy to talk about that, but I want to make sure that Andrea gets her chat in. So passing it off to Dr. Graham.
Thanks, Ashley. That was awesome. Really fun to see your video as well. And this is such a treat to hear everyone's presentations and to have a chance to close out on our 10-year anniversary celebration. I'm going to talk about my work designing a digital intervention for binge eating and weight management. And it really started by thinking about intervention strategies to address a theoretical model that was based in a clinical problem that I was seeing with patients, where patients were coming in that were struggling with binge eating and wanting to lose weight. And they were kind of, for lack of a better word, stuck in a clinical gap where they weren't able to really get effective services for both problems. And it made me think, why don't we have a tool that can do both? And so, but it occurred to me, this is a very busy model, that there's a lot of things we can do, a lot of different approaches that we could try. But actually, it's really important that we're not only precise, but that we're efficient. So as David started this whole talk, I wanted to avoid having a hockey stick approach where people would drop off after a few sessions. So we wanted to think about, how do I make this really an efficient tool, but that's also precise in terms of helping to lead to improvements, and that could be scalable to large populations in need. And as been the theme of this whole presentation today, it was also very important. My sort of favorite experience of these past few years being at CBIS is really embracing user-centered design efforts in this work, and recognizing that what I, as a psychologist, think people might want is not actually what they might want or how they engage with their phones. And so we engaged in a whole series of design activities over the course of I guess a long while, but engaging in several different design approaches. And I started with the initial question of just taking a step back, how do binge eating and weight impact your day-to-day life, and really engaging with people to better understand that process for them. And at the bottom of this screen, you can see that we've you had more than double the number of people in design activities as in our pilot trial. That it's just been such an important component of this work, is really embracing the need to engage with users to understand their needs and how to design for their context. So we've then developed Food Steps. That's the name of the program. And it really, I think the overarching, I would say both innovation, but sort of design implication, Kaylee touched on this in her work, is the need to actually be really flexible to users' needs and experiences, that people are coming into these programs with a whole lot of backdrop and backgrounds in terms of how they're experiencing different problems and what their different goals and motivations are. And how do we then align tools that can actually meet people where they're at and still encourage user-directed behavior change. So I show both my original model and our intervention to demonstrate the ways in which we've mapped our, we've grounded it in theoretically important, clinically grounded concepts, but made sure that it's done in a way that users are really driving their steps in this program. And so far, as I would like to believe, a testament to the design efforts, we've seen really high usage. So users are completing 80% on the program on average. And I should share that it's a 16-week program, so longer than what others in this talk have shared. This is a really long intervention in order to ensure that there was enough time to see clinical change, and that people are really sticking with this program. And compliance is high, where they're actually picking their challenges and engaging with the targets and completing their assessments on 94% of sessions that they complete. But greater precision is needed, where we're seeing people are improving week to week, but I would say that there's still a suboptimal proportion with weekly improvement overall. And so I've actually now hit what I call a design crossroad, where we're actually getting feedback from users of what to do next that are completely contradictory, which I love, where some people are saying, I'd like you to do one way in terms of how to set sequence targets week to week, and other people are saying, do it the opposite. And similarly, how do we deliver these tools to you? Some people are saying, I want to do it on my own, and others are saying, tell me what to do. And this is completely opposite ideas. So my next food steps, because I just couldn't get away with the pun, is that we have a pending R01 to do a micro-randomized trial to really understand what evidence-based targets are most impactful, when they should be delivered, and how, in order to have the infrastructure to build a just-in-time adaptive intervention that can personalize delivery in real time to users' needs. And more broadly, just to sort of wrap up the theme of today's talk, is also to then to think about where could we actually deliver this tool in clinical practice, and how can we integrate it. So I have an R03 award to be applying service design methods to actually engage with clinics around how do we implement food steps into their clinical workflows. And so I'll close by saying thank you so much for joining today. If you want more design resources, I would direct you to our website. We have lots of tools, and we look forward to continuing to engage with you. Thank you.
Well, thank you all. And I had hoped to have time for questions, but it seems we ran a little bit over. Let me just, I hope you don't mind all. I'm going to just put in the chat, our page, so that if you have questions, I'm sure that you can reach out to folks and ask them directly. But I guess that concludes our webinar for the year. So I wish you all a good summer, and I hope to see you back in September when we resume this. Thank you very much. Bye-bye.